Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today's topic is rhabdomyolysis, which can be a cause of AKI, acute kidney injury. So I got this blood result from back, and it's the creatine kinase, which is the muscle enzyme. And you see the normal range here, you might be able to see is, and my level is way over here. So it's like, what's going on? Do I have rhabdomyolysis? I'll get to my story at the end of the video, but first of all, what is rhabdomyolysis? Now, I've never been 100% clear on this. I always wondered, is rhabdomyolysis when there is a muscle enzyme creatine kinase elevation, or is it when there is associated complications from the elevation, such as acute kidney injury? So I looked into it a bit, and I'll let you know what I learned. Rhabdomyolysis is defined as syndrome where there's muscle necrosis and the contents of the muscle are released into the systemic circulation. These contents of the muscle most commonly are CK or creatine kinase, which can be easily measured in the blood, and myoglobin, which can be measured in the urine. There are other muscle contents that can be released into the circulation. Commonly, these include AST and ALT, thought of as liver enzymes, but are also present in muscle. So what about the CK creatine kinase elevation? They say rhabdomyolysis results in a marked elevation. I've not seen a clear, consistent definition on what constitutes marked. Some say greater than 5 times the upper limit of normal. Some say greater than 5 to 10 times the upper limit of normal. Some say greater than 5,000, but a marked elevation. So why do we care? Why do we care about this creatine kinase elevation? Why do we care about rhabdomyolysis? Well, we care because it can cause severe and even life-threatening complications. These include acute kidney injury, compartment syndrome, and some of the muscle contents that are released include potassium and lactic acid, so there can be life-threatening hyperkalemia and lactic acidosis. This can be a fatal condition. Getting into the acute kidney injury, this typically happens with very severe CK elevations, that is greater than 15 to 20,000. I've seen a risk score that uses a cutoff of 40,000, above 40,000 as a risk marker for acute kidney injury or death. It is not common with lower levels, less than 5 to 10,000. Rhabdomyolysis causes acute kidney injury by several mechanisms. One is vasoconstriction of the afferent arteria into the kidney. In addition, the myoglobin, which comes out in the urine, can be toxic to the proximal tubular epithelial cells and can combine with TAM horsefall protein to cause intratubular CAS, tubular obstruction. Although the acute kidney injury, when it occurs with rhabdomyolysis, can be severe and require dialysis, it typically is transient and does recover, kidney function does recover. So what are the causes of rhabdomyolysis? So there's 3 different groupings. The first are things that cause direct muscle trauma. So this might be a crush injury. This might be a situation where there is prolonged immobilization and muscle compression, or it could be something like ischemia during vascular surgery and muscle damage on this basis. The second has to do with exertional. So it can happen in endurance athletes, marathons, triathlons, can happen with resistance exercises, weightlifting. Risk factors for exertional rhabdomyolysis include things like hyperthermia, sickle cell trait, and there are some genetic muscle conditions that may increase the risk for this. The third has to do with the toxicity to the muscle. So toxicity can come from medications. Most commonly is statins, fibrates. Other medications can be involved like colchicine. Drugs, alcohol, cocaine can cause direct muscle toxicity, and metabolic conditions. Hypothyroidism can cause a significant elevation in CK, although typically not severe enough to cause acute kidney injury. Hypokalemia and hypophosphatemia are other metabolic risk factors. When do we suspect this? What are the manifestations? So classic manifestations include muscle pain and weakness, muscle swelling, and a darkening of the urine, red-brown urine, which is the myoglobin pigment. Many patients will not have all these manifestations. Some clues that there may be a significant creatine kinase elevation are if there's an elevation in the serum creatinine. Now, of course, if there's acute kidney injury, there's going to be decreased filtering of creatinine and it's going to be elevated. But even if the kidney function is normal, the serum creatinine can be elevated. That is because creatinine is a metabolite of muscle creatine. So if the body, if the muscles are releasing more creatine into the circulation, the creatinine generation will be increased, even without a decrease in kidney function. For more on this, check out my videos on creatinine, cystatin C, and GFR that I'll link in the description below. Another manifestation can be found in the urinalysis. So myoglobin, even if not severe enough to cause a darkening in the urine, can cause a false positive urine dipstick. So the urine dipstick dips strongly positive for blood, but there's no or very few red blood cells under microscopic evaluation. This may be a clue that something, the CK elevation or rhabdomyolysis, may be going on. So what happened to me? Before I get into this, if you're liking this video, please share it with someone who you think may benefit from it. It's spreading the message this way, word of mouth, that helps the channel and helps spread the message to more people. I had routine blood work checked. So my routine blood work included a serum creatinine, which was just slightly above the range. Since I had been doing a significant weightlifting regimen, I had, including lifting weights, about 12 hours before I had the blood work done. I was suspicious that this may be contributing. So we had two tests added. The first was the cystatin C to assess the kidney function by a different mechanism, and this came back completely normal, so showing a normal GFR, normal kidney function. The second was the creatine kinase, which, as you saw, was significantly elevated. So when can exertion, when can weightlifting cause rhabdomyolysis, and when is it a normal physiologic response? Done some research on this, and what I learned is that it is not uncommon to have a CK elevation after exercise, including resistance exercise. Typically, they are more modest. The CK elevation of greater than 2000 is classified as a high responder. There are some reasons to be a high responder. Some are genetic reasons, some different genetic variants. Others include the body's adaptation being used to that degree of resistance. So when the muscles are exposed to a load that they're not adapted to, the muscle cells do swell, and with this some swelling, the membranes become more permeable to creatine kinase, which is released into the circulation. Some other proposed mechanisms are increased oxygen demand and ischemia, reperfusion, injury. So what I did, in addition to drinking a lot of water and cutting back a bit on my exercise, I did wait about 3 or 4 days with no weightlifting and repeated my blood work. And the repeats, I'm now unfortunately in the green, 168. So that appeared to be the cause. Now, what happened? Was I a high responder, pushing myself and had a physiologic response, or did I have some muscle necrosis and a very mild case of rhabdomyolysis? I still don't know. There may be not a clear distinction. There may be a continuum. I do feel though that I probably did overdo it, and I would try to keep my CK levels a little bit lower, get more gradual muscle adaptation and overload. So if you made it this far, thanks for watching. You might as well hit like and subscribe. Leave me a comment. Let me know what you think. And until next time.